on HCBS reform for about 7 years. And we had a lot of things start in 15. And I've been a part of it since day one for the senior community and being a representative in the senior community. So I wanted to go over and kind of do a overview today. And then when we meet in November and December, I'm going to go through the specifics that affect the assisted living world and some of the better practices nationally that is going on. All right, so back in the 80s, the disabled community and the intellectually disabled community felt like they were being treated as second and third class citizens. So they started this major push to actually improve their world and be accepted as adults. More and more a percentage of their population actually was living into adult the world, where previous years, they would barely make their early 20s. So we now have a lot of older adults in their 80s and 90s that are intellectually disabled or intellectually disabled, and we weren't ready to meet them and meet their needs for both areas. So that was part of where it started. Then Colorado was really slow to get things rolling, and there was a national program called the Olmstead Act. Senator Olmstead had a disabled daughter, and she was discriminated against heavily, and it became his mission to make improvements. And so the Olmstead Act opened that door. In 2003, we started doing a better job in Colorado of mainstreaming and taking people out of what we called back in those days warehouse communities. We had one in Wheat Ridge, and they were, families couldn't take care of their loved one. They were placed at Wheat Ridge, and then they never saw the community again. And so that dissipated over time. We had one in Grand Junction, one down in Pueblo, one up in somewhere in that north area, and they have disappeared. So we do not do that kind of living situation for the DD and IDD community. We have host homes and group homes instead. But they started deciding that CGS, figured out early, and this is long before I had retired from my old role, that seniors needed to be included in this movement and not be left behind. So I went to an incredible meeting this week, a national meeting, and this lady named Paula Dressel spoke, and she said something that hit home for me because it's how we operate here and how I believe, is that equity is not through treating everybody equally. It's achieved by treating everybody justly according to their circumstances. And so we call it here meeting people where they are and helping them get to whatever level they want to go to next. And some of the people, call us back over and over and over again as they build their world out. And other people, it's a one-time thing. But I think this lady, is going to make a huge difference nationally in the next few years as a voice of what equity really means. The other thing we've been working on for a long time is the whole conceptual framework of person-centered. And person-centered is not a dollar figure. It's how we want to treat each other as human beings. COVID has brought out the worst in our country and some of the best in our country. And so person-centered is still a very big topic and a concept that I hope we will stay with. And so we don't want to put people in restrictions if they don't need it, but we do want to have people safe and in the right level of care for the right reasons. So just what we were just talking about 3 or 4 minutes ago, we have people in long-term care that need to come to assisted living. We have some people in assisted living that need to go to long-term care. We have people in the community that need to go to either one. And we have more people that need more services in their home for a variety of reasons until they're able to take their lives back and take on their own needs. So person-centered is a really wonderful way of looking at how you can provide services within your own community. And you think of it more as a coach. So it was interesting that Andy was on a bike ride, and if he was part of a team and was a coach himself or being coached, is to make improvements. And that's what we are doing in all of long-term care services, especially in Colorado, is using more of a coaching model than we are a telling model. So there's a practical approach to HCBS and a very practical approach to how we deal with each other in our communities. So first of all, you need to know that there's a person that you're talking to. And you want to talk to them about what's important to them. Even our most impaired people, and I can tell you downtown, we have some severely impaired people, and they don't want to come in. And we are not at a point in society of, what is safe and what's not safe when these folks are this impaired. But they do somewhat know what's important to them, and part of it is they want their freedom. They don't want people making decisions for them. That's what I hear the most out of them. In that work, we also have to, no matter what population you serve, you always want to try to promote individuality. And with individuality, what is your strengths, what are your interests, and what does dignity mean to you? And so another piece of this person-centeredness is how do we engage in our communities? Part of the work that we do at CGS and holding these seminars is to promote engagement within our industries, to work with each other and help each other out, because there's more than enough people to fill all of the needs or the beds. We don't have enough people to fill the needs. That's where our deficit is. There's a lot of work going on, rebirthing in what we call self-advocacy and having a voice. Even if you are at end-stage dementia or hospice care, or you're a little kid, or you're a disabled adult or intellectually disabled adult, to, that we try to listen to them and each other more. Another aspect of person-centeredness is financial self-control. We went through a long period of time where we became rep payees, especially in the assisted living and group home industries. And so the owners of the group homes would go to Social Security and become the rep payee so they could guarantee getting their portion of the money. And then they would give an allowance out, many of them every week, and they would portion with the leftovers and then divide it by 4 and give an allowance out. And then the folks would be broke by the end of the day. And whatever they bought, whether it was snacks or clothes or what, toys, whatever they wanted. And that period of time has really gone down. And so to get people of all abilities to be more financially self-reliant has been a big issue. The other reason that's financial self-control is back in the purview is that there was a tremendous amount of fraud. And we saw that in nursing homes, we saw that in assisted livings, we saw it in group homes, we saw it in the community. And so rep payee, when you really need one, because the person absolutely cannot handle finances, is extremely hard to find. So some basic concepts that I want to review is the very base of where we started in 2015. We wanted to get access to the broad community. In other words, not have people isolated. And 3 initiatives have happened in Colorado that are now national initiatives. So one of them is age-friendly communities. So most of the communities in the metro area have signed on to be age-friendly. And that includes libraries, rec centers, even some restaurants will serve your home in the afternoon, and not have other residents in or other people in from the community unless you want to. But they've trained their staff in the how to interface and how to have conversations with people. And so I'm hoping that comes back in the really near future. Then they wanted the people that needed help to choose who they wanted to be their partner. Many times in our systems, adult protective services especially, would just assign somebody and they had nothing in common and it was just a job and there was no relationship. And that has really went way down. We don't see that as heavy as we used to. So relationships are more important than ever. And now that we are gone through the hardest part of COVID from last year, I'm seeing that the relationships are going to hold a higher esteem than we even thought. Then we have a whole lot about rights and then autonomy. And again, people have the right to make bad decisions. I have a hard time with it. I've been practicing 50 years. I'm very protective. And I don't like it when we let people fail and fail and fail. And so I get really irritated with our system sometimes in that noise. And we just, I just don't think we've reached a really good solid balance. No matter whether it's choice or whether you change your mind. I know, in 8 years, 9 years, when I'm 80, don't wake me up in the morning. I will talk to you about noon. I have a routine. I don't think I'm going to change that. And, it's going to be very hard for me to live in a group setting when I have a very solid routine of what I like to do at this point in my life. So these are some of the new things that we have to be mindful of. And again, not easy, but doable. So a resident, when they move in, most of the time when we're looking for space, when we call facilities, or I call people that I work with a lot, I'll say, do you have room for a woman, or do you have room for a man? And they'll say yes or no. Or they'll say, I'm going to have room in a couple of weeks, and I know their homes, and I know what what they shine at and how they take care of folks. I'm not looking to have them make an approval of who their roommates are. I'm looking for the right situation at the right time for the right reason, and that's what most provider people that do advocacy work or case management do. Is they really are not thinking about roommate choice. In the DDIDD world, this is huge. Not so much in the senior world, okay? At first, when all this noise started coming out in 15 and 16, we thought that we were going to have to change our whole industry to private rooms. We got a ruling actually just in the last few weeks that you're not required to have private rooms anymore. And you don't have to convert shared rooms into private rooms. I was so glad to see that in writing, because that has been a rumor going on for quite some time. They do have the right to, learn about their new roommate. And in some facilities, people change roommates. So they may, start out with a roommate, and as they get to know each other, they change, and they want to change roommates, and that's perfectly acceptable. And we've done that in all age groups. If there is a space in the house that comes open and there's new roommates coming in, one of the things we was working on before COVID was to have the community interview the potential new resident coming in, especially in small facilities. And that was really working well in our behavioral health market. So this is what we went through in 19 and came to these agreements. So residents wanted to cook, especially younger residents. And some of my older people love to cook. At Ray's house, we had women that loved to bake, and that would always be a big event over there. So we need to have more assessments on if they're safe and what kind of help they need to be able to do things that they want to do. We don't want a stove to burn down or a kitchen to burn down or other things. So kitchen access continues to be probably the #1 safety issue that we talk about. And then second was food storage. So we had a heck of a time for a lot of years with bed bugs and mice and roaches and all kinds of other pests because of people hoarding food in their rooms, and it was uncooked or it got old and bad and they would hide it and all kinds of stuff. So we're doing better with food storage, but we're still working on this. The next big issue came with this mandated meal times. We still have especially in the ALR industry, trying to feed people at 4:35 in the evening, and then they don't get to eat again until 7 or 8 in the morning. It's way too many hours. So this is a big focus on the feds and on the state in all of the industries, that we have appropriate openings for people to eat, that we give them some more choices, and that they participate in menu planning. Smoking still continues to be a controversy on the federal level. We have put smoking restrictions in 25 feet away from buildings. Some buildings don't have 25 feet, so we go the farthest we can. Now, on the state level, they want you to be able to see them. At first, they were trying to force the industry to put a person in the smoke center during daylight hours, and so that they could supervise, and we had to push really hard to get rid of that rule. But in some facilities, some need more help than others, and so you have to figure out how you're going to handle smoking designated areas. And then the one that I've been deaf on and really irritated about was the sex workers and the overnight visitation. we finally just got a ruling again with this other ruling that just came over in the last couple of weeks, that you do not have to facilitate having sex workers or untoward visitors or homeless people that people wanted to bring in and give them a space to live because they felt bad for them, and all of those types of things that were going on during the rewrite of this. So this is a timeline just to kind of bring you up how long this has been going on for Colorado. So again, we were originally accepted in 15, just found out today that we're the first state to get the new federal funds. They're called ARPA funds, and we're the first state that got approved for our new HCBS expansion. So there's a lot of celebration going on at the state level and what that's going to look like. So right now, part of the goal of how this is going to look in the future so that we can serve people equitably, depending on their situation, is going to be important. And whatever we can put in place for sustainability will drive the bus. And that'll keep me motivated. So we have till March of 23 to do everything we can to make Colorado one of the shining states of services in the HCBS market. So any of you that are willing to get involved in this at whatever level you're interested, you can let me know and I will help guide you to the right groups to join. If you don't know about waivers, these are 2 waiver sites that will help you understand how Colorado's built. So when I came out of private practice to help Eileen in 2011, I was totally out of context with Medicaid. I hadn't been doing Medicaid for a long time. And so I was shocked that we had 16 different programs. And they all were standalones and they didn't interface with each other and they didn't help each other. And there was a lot of inner fighting and it was just chaotic. Well, we are now down to 9. And the goal is by 23, we'll be down to 4 in the adult market. And then the kids waiver is the same thing. So early, what we've been able to accomplish is we took like the HIV Ryan White program in the children's market and moved over to children's services. We took the HIV expansion program and we moved that into the elderly, blind, and disabled. We're working on the TBI program to connect to the mental health program where they can use their best practices together. And so there was a behavioral health meeting today. That's where I was at noon today, looking at the new structure of how behavioral health is going to interface in services across the board, whether it's in the street, whether it's crisis lines, whether it's mental health centers, whether it's hospitals, nursing homes, whatever. There's a lot of work being done to make a better alignment. And so I will continue to advocate for the voice of people, the seniors and the other folks in Colorado, that they can enter a door and they can get their needs met at that door and not backwards where the state decides what you need. So one of the things you may have heard is a term called attribution. And so they went willy-nilly through the list on a computer program and assigned people to a primary care. Some of them were across the state, like Grand Junction to Denver. Some of them were with OB services. Some of them were with children's services. It was an absolute nightmare. And we spent one whole month, Eileen and I did, just fighting, getting those attributions removed out of people's lives and getting that choice back. And so the voice that worked was this HCBS reform, is you took their voice away. So just because you want to do managed care doesn't mean that you have the right to choose to them who their primary services are going to be. So attribution started to wiggle its ugly head a few weeks ago, and I had to go and deal with one case. So I'm hoping that it's not going to go back to the level that it was back in about 15. So these are some of the milestones that we've been able to do. So for people that do Medicaid, so like for Ray as a new Medicaid provider, she had to meet all these criteria, and I helped her and she has done so. And some of you may have some of this coming at you. And so like Andy, that doesn't quite take any other than private pay, may find down the line he wants to change his business practice, and he'll know something about this because he's starting to educate himself. There's been a major cost analysis, and that was part of the noon meeting today. We're looking good in Colorado, actually. We are spending our money fairly wisely. We don't have as much redundancy as we used to have, and we are not wasting as much money as we used to, other than COVID dollars. And we have wasted a ton of COVID dollars in throwing out vaccinations, being one of the worst that concerned me and got my attention early on. All right, so here's where we are, and this is our win. So our policies and procedures in Chapter 7 are pretty clear. Our Volume 8 engagement for people that do use state programs is been clearing up and getting a lot easier to use. We have some new directives on how to do a lease and rent agreements with your residents. And that's what I'll be talking about in November, because we had to change a lot of that because it was so old and archaic. We're still dealing with photography issues. So unfortunately with social media, we had a lot of staff putting pictures of residents in homes, and not good pictures, out in social media. And so I think we've got that back in control and respecting privacy. But photography still is a concern for me. We have made the facilities less institutional, so they have door locks and house access. And some of our residents, like in dementia care, they can't handle that, but their families can. And so we have kind of quasi keys. They open any door in the house, but most of the folks with dementia don't really understand that. So they think they've got a key to their door and they feel safe. And then higher level functioning actual keys are, give privacy and protection of their properties. And then we're working on rights modification, which is the thing that I'll talk about in December, because again, even in the private sector, you cannot put a right restriction on any resident in the home, and it affects all the residents. And that's the basis of that one. And I'll be talking more about that in December. So then the review process, state was out all over the place looking at facilities and gathering information, and they're pretty much done with that. And I think they'll only go out if there is consumer complaints or violations. And they're looking at grievances in our state. Almost every department now has a grievance process, and then all the grievances go into a central system. And then that central system is looking at what category of grievance it is, and then what can we do in the future to decrease the number of grievances and complaints. And so the health department gets tons of grievances and complaints on pretty much a daily basis. And so they're one of the big ones that have to break it into parts and figure out what's really going on. You may, if you have any clients that are under the state waivers, may get a desk audit in the near future. They're doing some more work on that. And then one of the things that I'm also concerned about is that for facilities that are not totally up and have everything in good order, you may lose your ability to have a license with the state to practice in the assisted living or adult group homes, host homes. And so, agencies like ours are out trying to help everybody hit that compliance mark, and in the middle. We don't need to be at the good end on this. If we just hit the middle, that's enough, because there's an old philosophy in business: do enough, do it right, do it at the right time. And so I'm kind of using that attitude: do enough to satisfy, because you don't know when the rules are going to change again. And I don't want to give them too many people doing more than enough, because that gives them fuel to push the industry to do more than enough when we don't have the ability or the money at this time. So here's some of the things that we're working on. As I talked about, you can't put a rights restriction on somebody and call it a house rule. So I had a facility come to me. They had 5 pages of house rules that went to the shredder. We have 5 house rules essentially. And the first one is to treat each other with kindness and respect. And so at any rate, this is some of my newer work is trying to figure out how we hit this middle ground more appropriately. The term heightened scrutiny is very interesting. We have had a model in our state, especially in rural communities, where they have a hospital, a nursing home, and then possibly an assisted living all on the same campus. They're called swing beds. And for that community, for a long time, that's what they had. and they didn't have much of anything else. That is no longer a model that's going to thrive. And so rural communities are working under this heightened scrutiny. So we have about 19 in the state that are still working through with the state how they're going to diversify and make their communities a little more realistic for the people that live there. The other good thing that I'm super happy about is in Colorado, we have 8 regional areas. And so if you're in the Denver area, you're under Ray 1, which is Colorado access. And then the single entry point, which means that people on functional level, at all kinds of waivers, is done by Rocky Mountain Human Services. Or if you're in Boulder, you're under another Ray with Boulder options, Jefferson County and Jefferson options. So it's all based on density. What I'm kind of waiting to see, because we just got the new mapping for voting in the last few days, I'm going to be interested to see if the Ray structure changes again. We had a structure change last year, and I kind of anticipated it might go near what the voting patterns are. But at the moment, the Rays are utilization managers. So they look at expenditures and charges and outliers. Like how many times people fall off of a program and have to be put back on, that type of thing. So the Rays work's really interesting. Within the Rays, though, they have some specialty areas. And so behavioral health being one of them, and they're working with behavioral health markets and mental health centers to make better products. So in the single entry point, when somebody's new to Medicaid and they just apply, they're going to come into this initial evaluation period. And that's a financial at the county level and a functional with whoever the SEP is for their area. And so they have to do this big pile of work and figure out if they meet the criteria for that waiver. And if they do, then they approve them, and then they turn it over to a long-term care case manager, and they do what they call ITPs. We're super behind in ITPs. And so in the ITP world, it's an action plan, and it's the client who is using the state waiver, voicing their opinion on a whole variety of things they want. We were lucky. We were invited to the table and worked on it for 2 years on a new software system for the state, where people that can and want to will be able to do this once on a computer software system. It will go into a data bank, and then they won't get asked the same questions over and over and over, which stresses anybody out. So these ITPs will be based off of that data system, those interviews, building information over time, especially when people stay in services for long periods of time. And it should start improving our overall outcomes for a state when we have more interaction and more communication going on. So part of what's happening in 22 is we are building out phase 2 of the program, and I've asked to be part of that again. So I wanted you to look at how the process works. So it's really split between people under 65 and people over 65. And yet we have people that are under 65 that get the same benefits as people over 65 for certain programs. So this assessment that we're doing is we're looking at aging, but there is a movement to take age out of the factor. So maybe down the line, this will meld into one, which is what we've recommended. And then people, so getting back to that just clause is getting away from pinpointing or finger pointing or putting people in boxes and categories, however you want to phrase it, and just treating people to meet them for wherever they are, no matter how old they are. And then we have to play the financial approval. Well, this is where it gets sticky. Children waivers have different financials than adult waivers, and adult waivers have different financials than some of the senior stuff where you can, so adults can buy into a program where seniors can't after they're 66. Even if they're still working, it's really hard to get the buy-in in after you are 66. So we dabble in this constantly, but again, it's one of those things I'd like to see just pooled, and we just have one set of numbers for anybody in the state that are using services in one set of processes. On the functional side, we have another program called PACE that used to not take people under 60, and they have now moved down to 50. So they are helping with the disabled market. So the PACE contracts for services in assisted living and other in group homes and stuff are paying a higher rate than the state's willing to pay, even though the state did give a 2% raise. And then we have the assisted living and adult care communities that contribute to these assessments in these interviews. Where it gets tough, and especially in behavioral health, is when you have people in behavioral health go from one adult care home to another adult care home to another adult care home, and mostly due to behaviors and the skill sets of that home to be able to handle it. So the assessment is, why do you need it in the first place? The money, does it work? And what's your income? Do you have a trust? Do you get contributions from your family? Are you working? You have to go in and figure all that stuff out. And then assets. So we have what we call Medicaid qualifying trust that helps protect our young people. And those are great tools. Luckily, there's wonderful people that help put those together. I'm not one of them, but I know where to find them when I need them. Okay. So one of the things I want you to ask yourself is, why do we have all these different programs? Well, the majority of the programs were built because of crisis, not because that we were proactive in anticipating our care, but because we were responding to a crisis. We're in that right now with COVID. So we've spent all of last year pedaling like crazy, responding to a crisis. And Band-Aid here, Band-Aid there, fix this, argue about that, unfix this. And I'm considering almost to the tail. And the biggest fight is, are you going to wear a mask or not wear a mask? And are you going to get a booster if you need one because you're older, or you're high risk because you're younger? And then are you going to get your flu shot? And then are you going to have your other vaccines caught up? Because we're really behind in vaccines in kids. And so, like I said, we're kind of almost at the tail where we could stabilize, but we've got this new crisis brewing. So HCBS is just like that. We responded to a crisis. We responded to AIDS. We responded to tuberculosis. We responded to nursing homes, not having enough private pay. So they opened their heart to the state, said, yes, we'll take care of your people. And then all of a sudden, they don't have private pay hardly at all, because the assisted living industry birthed, and they took all the private pay market that they could get their hands on and was able to give a product for a lower price. And that spoke to the consumer. So I love looking at this on the economic side of it and see how we're going to go in the future. But it's really important that we got to stabilize this, and we've got to be very careful. So all of you that are here today, you have some responsibility towards risk mitigation, which means that if you do all the right things at the right time for the right reasons, you decrease your risk, you decrease your expenses, and you decrease your risk of being sued in court. And so risk mitigation is an important aspect of services. So the final setting rule that has been decided on is this statement. And this is what opens the community Office of Community Living, is provide services with significant disabilities with a manner consistent to the right choice, integration, and autonomy. And I don't believe this will change. I think this will be the mission for Colorado. If you're taking care of older adults or disabled older adults, which could mean 40-year-old people, they don't decline by choice. It's circumstance. And we're going to see, we've lost 700,000 people due to COVID, but in Colorado, we're close to 8,000 now. But we have over 2,000 or 3,000 people that have long-term symptoms of COVID, and they're going to become part of the new disability world. And so we're not really sure what that's going to look like yet, but I anticipate before I retire that we'll have a pretty good vision on that. Financial stability is really uncertain at the moment. There is a lot of prediction models that we're coming out. We're going to be an incredible country next year, and we're going to look so good, and we're going to be just shining all the way down to that we could be in a depression. And I don't know where we are. I just know that for a lot of the seniors and families I work with, stability is really tough. And then people just don't know where they're going to live. Prices of housing, the prices of apartments, the lack of subsidized housing, the lack of communities that can take people on low income, in the rural area, the frontier areas, the metro areas is all pretty tight. And so I think, we're either going to come out shiny or we're going to look like a pile of fools. So in the assisted livings, for the most part, we see EBD waivers, elderly, blind, and disabled, MI waivers. Then for the most part, that's the majority. And then for those facilities that have PACE contracts, which is a safe way to go if you're willing to expand, PACE could be a very good relationship. So here's the things that we can all do. It doesn't matter how we get paid. Maximize as many choices as possible. Continue to promote. Continue to encourage people to live a life in the community and have preferences and individualization. Be really, really protective of civil rights. There is enough people trying to take away the votes, and one of the votes they want to take away is all our people that are in any institution. And hopefully civil rights will hold on to that and not allow that to happen. And then to continue to be person-centered so that people can identify what's important to them. And we improve our pre-admission practices. We improve our first 30 days, and then we make our changes as we need to, or at least yearly. I want to talk a little bit about integration. Integration, very interesting in my lifetime, started back when I was in high school, where communities had to integrate children of minorities. And so that I was raised in a girls' Catholic school, and it was all white. And then towards the end, just as I was getting done to graduate, other minority families started coming in. When my children, I have 4, got into late elementary and early middle school, our community started being integrated. So they asked families if they would volunteer to bus to a minority area to go to school. And my children, I left it to them, and all 4 of them chose to do that. And it actually defined their adult lives quite a bit. And so they integrated over into other school systems. And as you know, integration has been a very slow mojo. Unfortunately, COVID has pushed integration back about 20 years, and we're going back to minority neighborhoods. We're going back to groups hanging out with their own groups more again, where it feels safe. I live in East Aurora on the other side of Buckley, and I live in a neighborhood that is definitely Guatemalan. And 10 years ago, it was totally military retirees. And so, things are just changing, very different. I'm not sure whether it's for the good or the bad. I haven't really thought about it that much, but it's just what I'm noticing. So community engagement on the local level and the state level is bringing all of these cultures back in and getting people comfortable with them and celebrating. So we just went through this in the last 2 weeks when we had the Mother Cabrini Day, which I didn't know was a thing, and we had the Native Indian celebration as a state holiday. And I don't know how I missed both of those changes, but I did until they happened. So again, it's part of that, what are we going to look like as communities, and how do we as Colorado want to reflect ourselves? And so, then what do we as a country? I think we're past the period where we cannot be, a part of everything, because we are a part of everything. We have every nationality and every ethnicity in the world lives in the US someplace. And so I think it's going to be interesting as you guys are younger, as you watch this and see what actually evolves over time. So some major rights, no matter how you get paid, be careful that you're watching privacy, be respectful, do not restrict, you're not a parent. Okay, you need to be very clear before people move in of, the community and how the community likes to function. And so that if somebody that doesn't want to live in those kind of standards can find a place that is more aligned to their standards, that's better, because we don't want people having to move so much. And then make sure people's belongings are secure. So my mother lived to be 101, and she had about 6 years of pretty crazy dementia, and then about a year of really severe dementia. And she was a pickpocket. She took everybody's stuff all the time. And her stuff was gone all the time. And so the other families, we all got to know each other really well. We knew our parents' belongings. And so we would just scour through the facilities and get everything returned. And we quit fighting with them because they immediately would, wander off and take it someplace else. And so, it was just part of that dementia world at that time for my family and what we did to survive through that. But it's important that people's belongings are secure and respected. And that you wouldn't believe how often that's violated in all sectors and all types of situations across our state. And then to promote independence, be respectful, and that when people do decide that they're going to live in a group setting, that if they're like me, I've been a widow now for 17 years, and if I had to go live in a group setting, that may take some work. Because I am pretty spoiled and I like my solitude when I want it, and I like to be in groups when I want it. So I think there's a lot of people a lot like me, then it's going to be interesting. I think your guys' generation is even going to be more interesting because isolation and lack of involvement in groups is even bigger in the younger generations because you're all got your nose in your phones. And that's where your social world comes from. So as you age and you watch aging go in your careers ahead of you, and then you watch the young people behind you, I hope you'll get engaged in the conversations of what they're going to need to be successful, because it's going to look very different than what I'm going to need. We have this whole thing about visitors. So it's another big hot topic. And I don't care what pay. We've had in private pay markets and Medicaid markets, and other kinds of markets where families bring in, or they want to let in a homeless people, or they want their son to stay with them 24/7, or the son loses their apartment and moves into mom's room in an assisted living or a senior building. Just a variety of things that we've seen over the last 10 years. So we finally got some visitor language, and we got some visitor language for the rental agreement. And so I actually put it on here. Visitors are not able to become an occupant. And so in the federal rules that help us, both in housing and in our industries, this will be part of the new agreements for the future, so that you don't get sucked into somebody trying to be nice and doing something they don't need. Now, there is a clause that if they need a 24-hour caregiver, and you accept that. So like you have an apartment and the person moves in, needs 24-hour caregiver, and you allow that caregiver to live there, then that's fine, as long as it's in the rental agreement, okay? Tenant law is new. It was voted on last year, and these are some of the highlights of tenant law. And so the basic bottom line is it mirrors what any renter in Colorado would be eligible for. Now, pay attention to the term eligible. We are under a lot of need of reforming renter rights and renter agreements, because we still have owners that want to be paid in cash and then claim that they never got paid and try to lock people out, throw their belongings in the trash when they're in the hospital. We've had a variety of things across the state that blows me out of the water. But the big thing is that your renters in your industries are eligible for, in Colorado, for any right that any renter in any property would be eligible for. And these are the list of things that would be there. So one of the projects I'm working on and trying to get people to help me with is, and Sandy's actually been part of this, is we're building a new one. And it's got to be in simple language, because the federal government says it can't have more than 7 words in a sentence and no more than 7 letters in a word. And that's not been easy. But we're trying to build a new one that we might be able to use, especially in the smaller industries. So what do you need to do now? Well, thank you for coming. That was wonderful. I'm glad to see you here. Keep working on areas that are important to the people you serve, and be accessible to those. Do not lose your person-centered conversations and your person-centered approach. Be careful with self-determination. When you invite somebody in, one of the first questions you want to ask is, why do you need to live in a congregate living? Why are you here? And it's not to get a meal, and it's not to have a place to sleep. That is not a good answer. And we've got to do a better job, especially in the assisted living world. Even for yourselves, because if you can do it for yourself, then you'll do it for others, is understand the whole conceptual framework of self-determination. So I may not agree that I like mask or I want to wear a mask 24/7, but I may do it when I am in high risk settings, even though I'm fully vaccinated. That's a concept of self-determination. And then ADA accommodations. ADA has been around for a long time, guys, and you cannot exclude somebody because they've asked for an ADA accommodation. Where this is getting sticky is pets. So comfort animals are not considered service animals. So in the regulation just came out, service animals that are certified and trained, which is the language, has to be an ADA accommodation. So we've got some problems in that world as well. Then there's other accommodations that may need to be made. And so if you understand what those are and what they look like, you won't find yourself on the wrong side. Communicate. Communicate heavily. And the more you communicate, the better your community will run, the better your relationships will run with other agencies. So one of the cool things about this group is that we have more than assisted living here. So we have an opportunity to build relationships and have great communications and still meet all of these standards. So in summary, toolkits are really important. It's how I function. I have lots of toolkits that I built, and when I'm putting things together, so I don't lose sight of them. And I learned to do that about 20 years ago. It changed my life tremendously, and I use it in my private life, and I use it in my professional life. And so this whole thing, this is a list of things that you should start having in your toolkit. And you can do an online, on desktop toolkit that can be a very useful tool. And then you might want some paper toolkits like we've done for COVID. So this is a list of administrative duties for everybody that's got a license with Colorado to have an assisted living. And I've been presenting each presentation to help people remember all the stuff that's in front of you and all the things you have to accomplish. One of the things that I've decided I'm going to do in December is we got some new directives on emergency preparedness. This came out of the last hurricane in Louisiana and the tornadoes that hit all the way from Oklahoma to Vermont. And then the fires in California, and then the fires even in Colorado, and the displacement of what's happened to people. So I just have pulled all that stuff. I've got it together in a folder. I'm going to start looking at it, and I'll be doing some sort of presentation probably in January on emergency preparedness for 22 and how to build a toolkit for that so that you can get ahead of the state, because there is a request to submit your emergency preparedness plan to CDPHE. And so they've kind of backed off a little bit because COVID's still kicking us. But I anticipate they're going to want in first quarter of next year. All right. So chapter 2, new rules come out in chapter 2, Wednesday of next week. And I'll be giving out the new chapter 2 in future talks. And again, it goes in that toolkit. I call it the Bible, where I keep all of the regulations together. And so just go on the health department's website next Wednesday and download the new chapter 2 and replace it with your old chapter 2. The reason you need chapter 2 is vaccination mandates more than anything. So some next steps, I'm going to be working on resident agreements and addendum items. I'll talk more about single entry managers and the interface with them, and then more about how to have more effective house meetings, and so that people know what's going on and you're keeping people informed. So if any of you are willing to help me be modeling and looking at some of the work that we've been working on, these are the 3 that I would like some feedback loops on. And one of them is the insurance agencies are asking for a sexual and physical abuse policy. And they didn't like what the state has, and they rejected that. And then they wanted more. And so worked with some people, we built one out, and we built out a toolkit and a mapping on it. And so I would like people to look at it and get some feedback on it. We have submitted it once to an insurance group, and they liked it, and they gave us an immediate approval and reissued the facilities liability insurance. So we may be pretty darn close. I'm hoping. Going to work on some new simplified resident agreements that are not lawyer driven. And then how we're building it is there's a core or the body of a resident service agreement. Now, this is not rent, this is services. And then you'll have addendums, because addendums will change. And then when you have a change, all you got to do is give a copy of the new addendum, get a signature, they got a receipt, and you're caught up, instead of having to do the whole resident service agreement. So that's how I'm tackling it. And then we have some new assessment tools. And so Ray actually helped with this to satisfy state requirements. And so we built a toolkit of dementia assessment tools, and I'm working on one for behavioral health, because those are the two areas that need something as, to work, that we can actually do the work we do more effectively. So I will turn this over to questions or thoughts. Take yourself off mute if